Happy All Saints Day. I'm Beth DeBruin. I'm one of the second-year pediatric residents. And this is Scott McLeod, one of the first-year pediatric residents. And one of the challenges pediatric residents face is counseling parents. And with the upcoming International Prematurity Day coming in a few weeks here, we thought we'd do a presentation on counseling parents of premature infants. So the Extremely Premature Infant, a Resident's Guide to Pre-Delivery Counseling. So case 1, you are a pediatric resident on your NICU rotation, asked to consult a 28-year-old primip at 24 weeks gestational age regarding anticipated preterm delivery. Mom asks you what the chances of her baby surviving will be, and if he does survive, what chances of severe disability he'll have. What do you tell her? Case 2, you are an expectant parent awaiting the imminent birth of your 24-week-old baby. A pediatric resident comes in to counsel you. What information would you like to hear, and how would you like that information delivered?
Thanks. So I guess some of the objectives that we'll be covering today, that we hope to cover today, are to review the risk factors and complications of extreme prematurity, present some local data regarding the outcomes of survival and morbidity for extremely premature infants. And then Beth will talk about some of the qualitative research that's been done regarding pre-delivery counseling and how best to take that on. And then we'll finally discuss an approach to the prenatal consultation. So just some definitions to start off with. One of the biggest things is, of course, gestational age. And this is the completed number of weeks and days from the first day of the last menstrual period. And so other definitions in terms of prematurity, full-term infant is anything from 37 to 42 weeks of gestational age. Premature is anything below 37 weeks. And the group that we're talking about today is the extremely premature, which is 22 weeks to 25 plus 6 weeks of gestational age. And that's according to the Canadian Pediatric Society's definitions. There's multiple ways to estimate gestational age. So this can be done by dates. As you can see, with everybody's familiar with those obstetrical wheels. And then the other one by ultrasound dating. And then the next one is by the Ballard scoring system. And this is a scoring system based on physical characteristics of the infant, such as looking at their feet and looking at the testes, and also the neuromuscular maturity. And so you'll see up there, there's a scoring system, and it's based on kind of flexed posture and the amount of recoil of the arms and other features. Ultrasound is, of course, the most accurate method if done in the first trimester, and it's accurate to within about 5 days. As you increase and go through the pregnancy, the ultrasound becomes less and less accurate, and so it goes to 10 days in the second trimester, and then it's quite imprecise actually if it's done much later than that. In terms of risk factors for why birth may happen prematurely, we've done a sort of Venn diagram because there's numerous factors that all interplay with one another. And so some of these are directly related to the mother, and these can include racial background, the age of the mother, the socioeconomic status. They can also be related to pregnancy factors, and this is like a twin pregnancy, placental abruption, other complications with the placenta like previa, infections, and anatomical differences of the uterus. Can also be related to the mom's health, and so this is things like obesity, nutritional deficiency, smoking, hypertension, diabetes. And these all have an interplay with one another. So preterm birth is usually very unexpected. We've just done a pie chart here to show that 2/3 of these preterm births are spontaneous due to preterm labor as a result of some of the factors that I've already spoken about. And 33% there'll be an indicated preterm delivery due to some of the maternal diseases like hypertension, hemorrhaging, and this is when things will happen urgently and will be indicated, but most are due to preterm labor. So moving on to kind of some of the complications of prematurity, there's lots, as I'm sure we've all sort of heard of some of them. And so looking at some of the pictures here, one of the first ones is the intraventricular hemorrhage, and you can kind of see some of the blood lighting up within the ventricles. The next one is the retinopathy of prematurity. And so it's hard as a kind of non-ophthalmologist to be able to appreciate this, but there's a picture up there as well. The next one down below of the abdomen is looking at the pneumatosis, and this is necrotizing enterocolitis, and this is one of the complications of extreme premature babies. And then looking at the lungs, there's of course bronchopulmonary dysplasia, and then finally the worst complication is of course death. And so this next slide is to highlight who exactly are we providing resuscitation for. And this is data from the Canadian Neonatal Network. And so one of the things I'll highlight is we're actually providing resuscitation for a lot of these infants, even as low as 23 weeks of gestational age now. 85% of infants at 23 weeks in Canada, and this is 2010 data, we're resuscitating. And as you can see, when the chart goes up, we provide more and more resuscitation, and then at 30 weeks, it's not that we're not providing resuscitation, it's that it's not as much resuscitation is necessary. And so that's why the curve drops off, in case you were wondering. So this slide gets to the type of resuscitation that's provided. And as you can see, at 23 weeks and 23 to 26 weeks, we're providing lots of resuscitation, and this includes intubation, positive pressure ventilation, some epinephrine, chest compressions. And as the gestational age increases, we need to provide less and less of the epinephrine and the more invasive procedures, but are still providing the positive pressure. And so how are we doing in Canada? One of the things that I was really fascinated by in this slide is the amount of difference that each day makes of the pregnancy between 23 and 24 weeks. And of each day of pregnancy, there's a 5% increase in the rate of survival from 23 to 24 weeks. And so this graph was mainly designed just to highlight how each day really matters. So there's been several large studies done. We chose this one in particular because it has very good data, and a wide body of data has been collected. So there's initial Epicure study. This is done in the United Kingdom, and then they're now on to the second Epicure study. And this is from 2006. And one of the things that I was really intrigued by is not only are we improving in our ability to resuscitate and improving in the survival of these infants, but we're also resuscitating more and more. And so, as you can see from this chart, at 23 weeks of gestational age, 22% of the infants are now surviving, in comparison with a lower number in 1995 was Epicure 1. And when you reach 26 weeks, and this kind of blew me away really, is that about 80%, or 4 out of 5 infants are surviving. And so this next slide is to highlight what some of the local data are, because this, as Beth will get to in her presentation on how to counsel parents, it's very important to present to them local numbers and local statistics when giving them facts about how their baby's going to do, what the chances of survival are, what the morbidities are. So some of the numbers that I'll highlight is, of course, I don't know. So we've got survival after being in the NICU, because one of the problems with all of the studies done on extremely premature infants is that the denominator, the number is different in how they calculate survival. So sometimes they calculate based on babies admitted to the NICU, Sometimes they include all births that some babies didn't even make it to the NICU. So the survival rate, if admitted at 24 weeks, and this is from data collected from 2004 to the end of 2006, the survival rate in a 24-week infant was 31%. And as you can see, it goes up dramatically. By 28 weeks, the survival rate was 94%. And so the next thing that people are concerned about, on top of the risks of being an extremely premature infant, such as the things we talked about like IVH, retinopathy of prematurity, chronic lung disease, there's also neurodevelopmental disability. And so I'll get to that on the next slide, what exactly we're talking about by moderate and severe disability. But as you can see, the disability rate kind of drops off, of course, with increasing gestational age as well. So it can start as high as 33% and it drops off to 7%. The other thing that I'll just mention on this slide is to explain the difference between the Epicure study and their resuscitation of 23-week infants and the Northern Alberta data. And it's because to a certain period of time in Northern Alberta, there was a policy not to resuscitate below 23 weeks. So this is also just presenting neurodevelopmental data from the Epicure 2 study. And it's just, again, to highlight, there is some very positive things that can be taken from reaching 26 weeks, because not only are 80% of these infants surviving, but also 60% of the infants are surviving without any disability. And this is in contrast to quite severe disability at 23 weeks of gestational age. So these were taken from a paper by Bolosetti, and it talks about what moderate and severe disability are. And so basically there's moderate disability with ambulatory CP, low cognitive scores, this is below 2 standard deviations, below the norm, visual impairment, sensory neural hearing loss that's aided, and they can hear well. In contrast, severe disability is now greater than the 2 standard deviations below. They're legally blind, so their vision can't be corrected. Their hearing loss is profound, and they need implants, but they're still not really hearing well. Or 2 or more of the moderate disabilities, and that's what we're talking about. So in terms of some other data from the long-term follow-up studies of extreme prematurity, and this is kind of, parents will ask questions about these sorts of issues because they may have heard of some of these things and not others. But the chance of cerebral palsy is very high in these premature infants. It's 70 times higher than the normal population values, but it's still around, different studies will quote different things, but it's between 5 and 15% is the actual rate. Most, though, will have mild disability, as I mentioned, and will still be ambulatory, and will still be attending normal schools. In regards to learning in school, a lot of the extremely premature infants will need help at school, but a very, very low percentage of them, 1 out of 8, will need kind of special schools and an adaptive curriculum. And a lot of this is due to issues related with working memory. Some of these infants will have behavioral problems, and this is found quite frequently. And things like ADHD have been studied in follow-up studies. Chest problems, this can include, some studies have shown a high linkage with asthma, others have not. But certainly there's more evidence of airway obstruction on pulmonary function testing and lower exercise tolerance due to this. In terms of growth has been studied extensively, and it's shown that they are slow growers, but there is catch-up growth, and most are reaching puberty at the same time and reaching their genetic potential in the long term. However, one of the interesting things from some of the follow-up studies is showing that in those with very low birth weight, which is kind of correlated with early prematurity, there's a loss of bone density. And so the impact of what this loss of bone density has on these children has yet to be determined. And so now that we know all this, I'll let Beth take over and talk about the management.
So knowing what we know about survival and disability, how on earth do we know who to resuscitate and what to tell parents? Well, many scientific societies around the world have issued guidelines regarding the care of extremely preterm infants. For example, the CPS and the SOGC in 1994 and again in 2000 came up with guidelines. Similarly, the AAP along with the ACOG in 1995 and 2002. The UK Nuffield Council is a huge body of literature that we look to. And then finally, the new CPS statement of 2012 gives us some guidelines. However, with all these professional bodies giving guidelines and recommendations, no universal consensus exists regarding management of a newborn. In general, the current standards recommend intensive care for the over or equal to 25 weekers, compassionate care in the under or equal to 22 weekers, and then an individual approach in between at 23 to 24 weeks, consistent with parents' wishes and the child's condition. So what does the CPS state? Well, this is the position statement that came out this year from the Fetus and Newborn Committee. At 22 weeks, survival is uncommon. We take a non-interventional approach and we focus on comfort care. At 25 weeks, we know that there's improved survival and improved neurodevelopmental outcome. Active treatment is usually appropriate unless there are significant other risk factors. And at 23 to 24 weeks, active treatment is appropriate for some infants. So the prenatal consult. When I was a resident at Memorial University in first and second year pediatrics, I was asked regularly, multiple times a week, to counsel parents with anticipated preterm delivery. We had absolutely no training, no statistics, nothing to go on, and all of us were told just to go see a woman in the middle of the night if she was expected to go into preterm labor and had to know what to say. So I thought that was one of the impetus behind our presentation today is you need a starting point. You need to know something. So a prenatal consult is when a staff neonatologist, pediatrician, NICU nurse practitioner, fellow, or resident is asked to consult a pregnant mother, plus or minus her partner, about an anticipated delivery. The challenge is that most families have not planned on a preterm birth, they're unfamiliar with problems of prematurity, and they're uncertain about the outcome of premature infants. So the consult is typically done during a time of high stress. So you've got the perfect storm. You've got a mom in labor, in pain, perhaps on medications. You're breaking some sort of bad news. You've got scared, stressed out parents, and you've got a whole whack of uncertainty. So it makes for an awkward, unpleasant experience for everyone, or can make for an awkward, unpleasant experience. So the consult experience, what do we know about it? Well, a really recent study, October 2012, out of Ontario, 3 pediatricians, took a look at how we can improve pre-delivery counseling. They did 10 face-to-face interviews with families of extremely premature infants, and this is what they found. First of all, parents had no previous knowledge about prematurity. Before being counseled, in fact, most assumed that with extreme prematurity, there was no chance of survival. One mom said, "I didn't even think it was an option to have a baby at 26 weeks. We were, in all honesty and bluntness, prepared to have a burial for this child." Parents also want prioritized information focused on immediate risks to their baby. One mom said, "Going into great detail beforehand added a lot of stress. It would have been a bit more compassionate to tell us that we'll deal with it once the baby arrives." And parents want more opportunity to explicitly state their resuscitation wishes, even if the ultimate decision is up to the neonatal team. One mom said, "To be honest, if somebody would have told me that this is what my life would be like, I don't think I would have chosen resuscitation. I might have chosen to hold him for the 7 minutes he cried and let him die." And parents want early and repeat counseling. Dad said, "I do wish I was more prepared. We were there for at least 3 days before we had the baby. Even some literature or something would have prepared me more than the shocking conversation I had with 3 doctors after the fact. I'll never forget that as long as I live." So counseling, according to the CPS, involves 3 things: building a rapport with the family, accurate information giving, and shared decision-making on neonatal care. And again, this position statement in 2012 says that information giving should be accurate, updated, and local, and consistent. So there could be some joint counseling from obstetrics and NICU, and within the NICU, if we had case management rounds like Dr. Reichert does to help solve inter-team disagreements so that we're all on the same page. So what information do parents want? In order, from studies, parents want to know chances of their baby's survival, medical problems the baby might have, risk of disability, and treatments the baby might need. But the information might not sink in. As qualitative research has shown, parental experience of a preterm birth is a time of grief because you've just lost this normal pregnancy. And it's a total shift in identity, one from a normal family to no longer a normal family because you have a potentially disabled baby. And so parents tend to dismiss negative statistics and trust and hope that a better outcome will occur. So that begs the question, do we give exact stats or do we give generalities? Well, the studies have shown that the majority of parents prefer exact statistics about infant survival and outcome. But Annie Janvier out of Montreal has something different to say. She's a neonatologist and she's also a mom of an ex-24-weeker. And she said telling parents their child has a real chance of dying doesn't necessarily require reciting statistics. Instead, words are more meaningful. You could say something like survival is likely, or survival is unlikely, or at this time, we just don't know. It's impossible to predict. The studies show that parents uniformly are more positive than physicians regarding the outcome of their infants, and they value religion, spirituality, compassion, and hope when making decisions about resuscitation. The CPS also says in order to build a good relationship, we need to endeavor to understand parents' unique experience, culture, and values. Each family is different, each baby is different, and we should make our interactions ideally free of personal bias. And regarding joint decision making, we should be meeting with parents several times, not just once, ideally. Actively engage parents and invite their participation. Yes, some parents want to be super heavily involved. Some do not want to carry the burden of making a decision, and others are just too overwhelmed. But at a minimum, our job in the NICU is to ask, how would you like to be involved? We need to educate parents on what their choices are. We need to make parents feel supported in their decisions, and we can use decision aids to help. Guyen out of Montreal is doing a pilot study on the use of decision aids for resuscitation and care of newborns. And they've come up with diagrams on what a baby's going to look like when they're premature and what kinds of sort of machines they'll have attached to them, because some parents are just shocked at what their baby looks like. And they've given visual aids on survival, on long-term disability, and on the different morbidities that we talked about before, the chronic lung disease, the interventricular hemorrhage, and the retinopathy of prematurity. So visual aids that parents can hold on to and use as a discussion point. What do neonatologists think? So a recent study out of Harvard a couple of years ago looked at regional prenatal counseling practices, and they found that almost 60% of neonatologists see their primary role as providing facts to parents, but only less than a third felt their main role was to assist parents in decision making. Almost 100% asked about mom's understanding of facts, but only 42% regularly discussed quality of life issues, and only a quarter regularly ask about parental spiritual or religious beliefs, which is what parents have identified as important to them. So what are we doing well? Well, we're giving information really well. 80 to 100% of Canadian parents respondents said, consultation helped my understanding, it was overall useful, the doc gave me a chance to ask questions, the doc explained things to me in easy to understand words, and the amount of detail given was perfect. We're also doing relationship building well. Around 80% of parents felt a high level of trust in the physician, and they felt that the physician showed a high level of compassion. So what are parents' recommendations? Well, they say they want information on prematurity way before they deliver, so way back when they're visiting their obstetrician. They would like pre-delivery counseling started as soon as they're admitted, ideally, before labor, before pain, before medications affecting cognition. And they would like the initial pre-delivery counseling to focus on issues of immediate relevance, survival, morbidity, details of the delivery, and what my baby's going to look like in the NICU. Parents would also like written and visual information with counseling, because sometimes the stats just go in one ear, out the other. They want ongoing counseling, not just a one-time only. They would like both parents or a support person present. They want to be asked explicitly about their resuscitation wishes, and if we are deciding to resuscitate, they want us to display hope and compassion. So how do we do this? The approach. Well, as Dr. Chloe Joint has in her office, she has a guide, an approach to pediatric fellows going in to do a prenatal consult. And she says, be prepared. Read up on your case so you know what the family and the baby is all about, and grab your stats so that you have something with you that you can refer to. She says, explain the situation. So when you come in the room, introduce yourself. Hi, I'm Beth. I'm from the neonatal team. And do you have any idea why I'm here? I'm here to talk about your baby that might be coming earlier than you thought. Start where mom is at. So rather than jumping in on stats and saying all the different morbidities, just say, what do you know about prematurity? Have you ever had a premature baby? Have you had a friend with a premature baby? What do you know? And start from that point. And then inform by talking slowly with no jargon, like MEC, NEC, IVH, BPD, all the acronyms we use. Start with the basics. So your baby is being born earlier than we thought, and he's going to be taken to the neonatal intensive care unit, where we're going to do this. Talk about immediate events and the morbidity and mortality that we know from local data. And overall, Chloe says, be the good human beings that you are. Sit down, make eye contact, listen well, and empathize.
So I guess at this point we'll come back to the cases now that we have heard lots of information. So again, you're the same pediatric resident and you're on NICU, and you've been asked to do the same consult on the 24-weeker who's about to deliver. And so mom now asks you what the chances of survival will be, and if he does survive, what's the likelihood of disability? And so I put this to the audience.
What do you tell her? Chances of survival based on local data?
So I guess the best way to do this is to grab your stats. So we'll just
Do you remember? Is it 80%?
31% based
Okay.
on local data.
And
And
you-
then the disability,
About a third as well.
yeah. So there you go.
And just go back to that. Okay, that's right. Okay, now if the roles are reversed and you're an expectant mom awaiting the imminent birth of your 24-week-old baby, pediatric resident comes in to counsel you, what information do you want to hear? What have the studies shown us what parents want to hear? Come on. Chances of survival. Quality of life? Yes?
They may not think of it, but having been an email fellow way back, the question they should ask is, what is the neonatal team's philosophy on looking after severe complications, such as grade 3, grade 4, cranial hemorrhages?
Okay, so our point of view. Okay. They also want to hear, what's my baby going to look like? And what's the NICU all about? What are you going to do with him? And how would you like that information delivered? Would you like do they want exact statistics? Do they want broad strokes? Do they want a rush job, one time only? What do parents want? Repeated counseling with statistics, and they want us to take a compassionate, hopeful approach if we're deciding to resuscitate. Any comments or questions? Okay. Hi.
Thank you very much. Your slides were very, very clear. Maybe hit the other slides first.
Okay.
Hi, Scott, Beth. It's Color State here.
Repeat the questions, please.
The Royal Attic.
Hi.
Hello.
Very good presentation. Thanks very much. Scott, we spoke beforehand about this issue. I think Annie Jambier has done some fantastic work on consultation before delivery, and as you know, she has a 24-weeker as well, who's survived and is intact. I just wanted to make a few points. The first is, it's really important to put extreme prematurity into context. Today, extreme prematurity is considered in the same way maybe Down syndrome was considered 50 years ago. We know that children with Down syndrome have a worse neurodevelopmental outcome than children who are born at 23 and 24 weeks. So, 50 years ago, we would have said Down syndrome, particularly with cardiac defect, should be considered a palliative serious condition and not be, and the option for resuscitation wasn't there. Well, we're at that situation at 23 and 24 weeks now. So it is unusual in the pediatric literature to have a condition with 33% survival, where we would counsel people not to resuscitate. We don't do it in emergency. Neurosurgeons don't do it. Oncologists don't do it. And cardiac surgeons don't do it. And I think that the CPS statement has to be put into that perspective. And Annie and Joby has done some very interesting research on this to show that the preterm baby doesn't have the same moral value to society as other babies or adults with other conditions. The second thing is, I completely agree with you. This issue of antenatal consultation needs a lot of study. It's not something which can be done on the spur of the moment or on the cusp. It needs to be something which people need to be trained in. We shouldn't be sending people to talk to parents without adequate information. I think the third thing which we're coming up against in Edmonton, and one of the reasons for our shifts in how to resuscitate, is we have a heterogeneous society now. We have parents who understand, with different understanding of what it means to be disabled, or what it means to have intensive care. And we've seen recently in the media parents who would like everything done for their child in the face of unassailable odds. So I think this is a shifting ground, that's what I'm trying to say. And what you're putting forward is in the situation of shifting ground, we really need to respect what parents want and inform them and practice more as facilitators than as directors of care. Does that make sense? I mean,
Yeah, thank you.
I'm not really asking a question, I'm making a comment.
No, thank you for the comment, and it's fascinating what Annie Janvier has to say, because she comes at it not only from a neonatologist point of view, but from a mom point of view. And she said her whole way of thinking shifted after she had a babe and had the prenatal consult. And she goes not against medical evidence, but she says years and years of neonatologists saying their opinion and giving medical facts, but what exactly does the parent want to hear? And she's funny when she says it too, and I think that she's really been an instigator in this whole paradigm shift. Other comments?
No, I was just, I'd be careful when you make conclusions based upon studies which ask what a parent wants to hear. A parent may want to hear exact statistics, but honestly, we don't have exact statistics, especially for their particular child who's in front of us. Even the chart that you showed us right now showing 31%, if you were to tell a parent, well, there's a 31%, that's implying a false sense of certainty in terms of what the outcome's like. If you actually look at the numbers you have there, I mean, and talk to the parents with some sense of confidence intervals or ranges, you'd actually probably be more honest to them about how certain we are with regards to what outcomes can be like.
You're right. The qualitative research is showing that...
Can you repeat the question? Because it doesn't pick up.
The comment was that, I think, if I'm framing it correctly, we need to be careful about quoting statistics to parents based on large numbers of babies and not their individual baby. And we need to affirm uncertainty in prognosis.
Well, I guess I would, when you take much of the qualitative literature around neonatology is not very critical. It's often asking people for their opinions of what do you think we should do. That doesn't necessarily transfer into what we ought to do in all situations, right? And I would be careful. Parents might want exact statistics, but I would ask you, do we actually have exact statistics for their particular child? The other comment or question I'd like to ask you is, I mean, this is all very, very interesting, right? I'm thinking of a child who comes into the pediatric emerge with E. coli meningitis. What would it look like if we came to that parent with pictures in terms of what the therapy would look like, what the brain might look like on MRI imaging or CT scan? I think many people would say that's perverse or ethically inappropriate. You don't show a parent all that information right then and there. They're already coping with so much. And sometimes it seems when we're counseling around prematurity, we're giving all these numbers because we have them, right? That's what's in the population studies. But really, antenatal counseling should actually be perinatal counseling. We talk to parents both before the child's born and after the child's born. And depending on the particular situation, the particular parent, some information is more appropriate to talk about after the baby's born.
How do I summarize that one? Just because parents want exact statistics doesn't necessarily mean that it's appropriate to give them exact statistics.
Well,
We don't have
We don't have exact
statistics.
statistics.
And I guess the other comment was, for other conditions and diseases, we don't necessarily present them with gory photographs saying this is what the baby's brain looks like, this is what they're going to look like. So why do we do that in neonatology?
And I'd be very curious
Yeah.
in terms of what your thoughts are.
And I guess, well,
Just to be clear on Guillen's study, this is just a pilot study that they did with just a handful of parents who had already had premature babies, and said, if we had come back to you with pretty pictures, would that have helped you make a decision? And across the board, yes. So this hasn't been done yet.
For sure.
Yeah, but I don't know, coming from someone who's been there in labor and pain and scared, maybe I would have appreciated a picture. I don't find these gory. I find it really useful that I could have sat down with my hubby and gone over this and thought about it. I don't know.
Can I give a comment from the Alex?
Hi.
Hi. Very nice presentation. I think when we are doing many of these consults, everyone is so different because we used to be consulted many times when there is a treatment in preterm labor. That doesn't mean that the baby will deliver. So we always hope that maybe the baby won't deliver right away. So we try to adjust the information according what the parents want. At least some of us, the approach is to ask the parents really what you want to know. And I know some of them says, we don't know anything. So I try to concentrate in the big picture because I think it's very stressful for them. Even for us, sometimes we don't have the certainty of the very accurate information. And we need also tell them we don't know. So we can present with the data that even sometimes is not very precise. I know it's difficult to try to have some kind of guideline, and we can end up having some very big picture, how can we approach. But regarding the content, I think it needs to be more individualized, even if we need to have an agreement how we will approach regarding the weeks of gestation and the chances that the baby may have in general. I think we need to individualize more what the parents in that situation want to know, what they want for the ones that they have all the statistics. Of course, we can give them and say, well, the statistic is a number, but doesn't mean that always apply to us. Or for the parents that they don't want to know much, give the whole picture how the baby will be at the delivery time and then go from there. Because mostly the studies, what they show is, whenever we talk with the parents at that time, they don't remember at all. So even if we give much and much and much information, and after the baby is born, they don't even remember they were seen us.
Right, right. Thank you.
Just to comment on the word care, I find it really unusual, I guess, especially in the NICU population. The slide from the Epicure talked about intended care instead of intended life-sustaining treatment. And similarly, in my role in palliative care, we see lots of perinatal consults. And the number one question parents always start with is, what do they mean by compassionate care? Right? And so we use it as a euphemism in the NICU for withholding life-sustaining treatment. So I think we need to be very clear about what we mean with families, but also to emphasize that regardless of the treatment path we take, their child and their family will receive care.
Yes.
And just a last comment, there's a really neat one-pager in the CPS journal that I received this week from a woman named Michelle Ryan, who is now a resident at Alberta Children's, but had a 24-weeker that died. And the one comment she makes in this one-pager is that we are trying to implore or to connect with families' rational side, and parents in that situation do not have the capability to be rational. And I think that's something we come up against again and again.
Right.
So that we need to acknowledge it's not this sort of objective weighing of balance, like burdens and benefits.
Right.
It's not that at all. It's all this feeling stuff, and that's why it takes so much time.
Yeah.
So the articles that Dr. Davies is mentioning, they're actually all found, three of them, the CPS statement, the article that Dr. Davies is referring to, and as well the qualitative study are all found in October Pediatrics and Child Health of this year. Yeah.
I think it's important to recognize too that we all interpret outcomes in a very different way. I remember as a PEDS resident going to the neonatal clinic, and there was this little 18-month-old gorgeous bright child who had a severe hemiplegia, and the physio was saying, maybe this kid should not have been resuscitated. I'm thinking, this is just bizarre, right? That to her, that outcome was terrible.
Wow.
And so the rest of us, this child had really an amazingly good outcome considering the whole story.
Right.
The neonatologist said we just follow up had this funny line that he would say when we did rounds, and he'd say, maybe this one will only cook a 2-course meal rather than a 3-course meal, but does that really matter?
Oh, goodness.
Question,
That is-
yeah.
that is-
First of all, I think that's a good presentation, and I encourage you to apply to neonatology fellowship.
Thanks.
So, I have a comment and a question. I think comment is the question is, do we give recommendation to the parents or not? I think that question was. Do we give recommendation to the parents or not about what path to take? Because as mentioned, that several people mentioned that these parents are in shock and do not know what a severe disability means even later in life. Not given alone their course during intensive care. The second is, you present well that 66% of these babies present way in emergency, right away, and they're going to deliver right away. It's not the 33 that we anticipate prematurity, and we know that the rate of prematurity has never changed in Alberta over the last 20 years. It stayed exactly the same. 1 in 10 babies are born prematurely. The question is now, do we, and I like the Montreal picture that you gave on that premature baby. So the question to me is, should we, that starts during pregnancy. Once you decide pregnancy and you go to your obstetrician early in pregnancy, they have that information already, or have some information about prematurity.
Yeah.
1 in 10 is going to deliver prematurely. Yes, the majority of them are going to deliver later a normal outcome, but I think they have at least some understanding of what extreme prematurity is about when they are in a good mind state.
Yeah.
Some of them will dismiss it.
When it's not an emergent situation.
It's
Yeah.
not an emergency situation.
When you're walking around the hospital here, you see pamphlets on RSV and meningitis, and you can imagine how that would add to the pregnancy if you go to your OBGYN's office and you've got a pamphlet there on extreme prematurity with pictures like that of what to expect, and that's the time to start asking. Yeah.
And then I guess regarding the initial question about whether we should be giving advice, I think it sort of comes back to the point where people want to hear some of the statistics, but they don't want advice given to them. We just want to provide them with an individualized approach, but present them with data that will assist them in their decision making.
And I disagree.
One of
I
the
disagree.
things that I'm just going to put a caveat to that, though. One of the things that we can present to them is when survival is likely and when survival is not likely.
And I would say probably the most common question you get asked in an antenatal consult is what would you do?
What would you do? Yeah. You have a baby, what would you do? You have a daughter, what would you do? Across the board, the qualitative research shows that parents retrospectively feel like they were too overwhelmed to deal with the decision and would much prefer that the neonatologist take on that burden of the decision of resuscitation or not.
That's not across the board. You can't. There's a number of studies in the States which actually come to different conclusions. To be careful.
Okay.
Just that in answer to that, there's a good article by Lainey Ross, and it's called "Why the Question, What Would You Do, Doc, If This Was Your Kid Deserves to Be Answered." And so I think we've gotten so into respecting people's autonomy that we are scared to give an opinion sometimes, even when it's directly asked for. So I just encourage you to
Okay.
consider that.
And I can weigh in on that with, being a pediatric nephrologist and having to break bad news to children that come in with chronic kidney disease or babies that are born. We do have a discussion, but if the parent specifically asks, so you don't say, if it's my child, blah, 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 this is what I would do. But if they ask that question, then you weigh in on that. So you give the parent the autonomy or the separate, decision-making ability, so they can discuss their family and then come back to you, whatever. Because this is not, as you said, not a one-time interview or consultation or interaction. So I'm going to turn it back. Let me ask one question because it's sort of going in the direction that I want. So because if all what you said is what you believe in, because there was a little bit of a sort of disagreement between the two of you, if you have that 24-weeker, the mom is in labor, and you're going to do the consultation, how would you actually, so could you, because we have time, could you act it out to show us from what you have learned, how you would actually practice it, and also whether or not you would follow it up in the NICU afterwards and how you would do it? Because that's what you're recommending. Go.
Who do you want to be?
Who do I want to be? My worst fear. So the exact question is, how would you go about doing this consult?
Yeah, so let's say if you're the mother, or Scott, you can pretend to be the mother, or the father,
Okay.
how would you do this? How would you counsel? So you've introduced yourself, you're the, pediatric resident in the NICU, coming to do the consult, all that part is done, but the actual counseling part.
Do you want to be?
That's
Go for
the
it.
OSCE question, so we put it for the OSCE exam.
Yeah.
Yeah. So I guess if Beth is the mother who's about to deliver, I would come in and she'd obviously know that she's in labor and all that. So this is kind of an artificial situation. But I guess the first thing to do is to come. I would come in, take a seat, make sure that I was kind of in it, that Beth was as comfortable as can be in labor, and I was sitting down and paying attention to her concerns. The next thing I would say is ask her about her current knowledge level to
So
try and
ask Beth.
So Beth, what do you know about extreme prematurity?
I don't know very much. This is my first baby. I'm young. I'm terrified. I have no idea. I don't even have a friend that has a premature baby.
Okay.
This wasn't supposed to happen. I was supposed to be pregnant until February.
No, absolutely not. And so I'm here to.
Mind if I interrupt for a minute?
Thanks. Yeah, great. Thank you.
So the point that I was trying to make before.
This is a very unfair.
No. The point that I was trying to make. No. The point that I was trying to make is exactly that. Is that it is such a difficult thing to do. So what we present as a content and as a lecture and a presentation is far, far different to what we actually do in practice, because it is extremely difficult. It depends on the interaction, the questions that you're going to be asked. And I think that's the point that you were trying to make, is that we can have all the statistics, we need to have the confidence intervals, we need to know what the local practice is, we need to know what Canada-wide practice is. We also need to know what happens south of the border and other parts of the world. But all of that information is released only in an appropriate manner within the interaction that you actually have. So it may not be completely controlled for you to go in there and say, these are the stats, because the questions that you asked at the end of the rounds was 24-weeker, specific questions. What do they want? What do they want? And it may not be that. And that's, I think, the point that he was trying to raise. And that's all I had to say. So I wasn't being unfair to you. I just wanted to show it that it is difficult, not just for you guys, for us too.
No, it's
we
awful.
do this
It's
all the time.
Awkward
It's
and
very
stressful.
difficult.
Another thing, one very important thing, as you mentioned, this is not a one-time off. This is a whole series of interviews and meetings with the person. All that information you cannot give in one
time.
session.
Yeah.
That's going to come along.
Yeah.
And I think until you say one of the most important things, you build rapport with the parents, and then at the end. So in one session, just deliver and the baby is going to deliver now.
No.
That's not going to. All what at that time you will be focusing at resuscitate and later talk about all these things
Right.
at great length as the baby is in the NICU.
So taking it one step at a time.
One step at a time.
There's, I don't know, who was first? Go ahead.
Thank you very much for your presentation, Brenda Scott. It's a very nice one. And I want to make a couple of comments and questions about how you think about the antenatal consult. First of all, for the antenatal consult for 24 weeks or even 25 weeks, I don't think any of us at the Alex will ask the pediatric resident or even the first 3 months fellows to do the consult. It's such a difficult, challenging job to match the art and the science in talking to the parents. So that is the comment about this antenatal consult for extremely premature, very viable immaturity. And this comment that I want to, the question that I want to pose to you is I find the statement that you said the early distribution of the information of immaturity to the parents are very much being hoped for as from those parents with immaturity that you survey. And personally, I don't have any problem, and I think we should have some pamphlet or some kind of information flash sheet about immaturity or extreme immaturity that in the obstetrician or family doctors' clinics. On the other hand, the active distribution of the information parents as a way to well, prepare these parents, I'm not sure it's appropriate. Although in this survey that you find that the parents are actively asked for this kind of information, but it may be from a biased population, because for those parents that you're serving really have the prematurity. What we're missing is 90% of the delivery near term or term, only 10% are preterm, and maybe only, a fraction of that 10% is premature, extremely premature. Are we kind of overdosing, over-distributing the information to those 90% who really have term delivery?
Right.
So just to repeat the question, I guess, for the mic, it's basically, does the average parent who has a normal birth need the information on premature birth?
I want your
and the opinion,
on the active distribution of this information to those to the general population of mothers.
And if I were to guess, I would say they probably don't really want to see that, because they want to remain with the belief that everything's going to go well in their pregnancy, and that's the male opinion.
Maybe there's a point about the timing at which we give the information. In prenatal classes, when you're 30 weeks, 32 weeks, or a little bit before, and you go to classes, we get inundated with pamphlets on car seats and bottle versus breastfeeding and all kinds of stuff. And maybe it would be good just in one of the prenatal classes to have a talk about it, that not all babies are born term, and these are some of the complications that can happen if they're preterm. Maybe when you're closer to delivery? I don't know. I'm one of those people that would appreciate the more information the better, but I know what you're saying. There's no point in harping on something that's 1% to begin with.
That was very thought. So one thing I know is that families will usually go to the internet. And so instead of having them go just generally to the internet, do you have an internet site that you would recommend? And so that they're not searching
Incorrect places.
Dr. Leonard, I think that a really good site is actually the Epicure. They have an excellent website that's very accessible to parents and researchers alike. They present the facts on the Epicure website in a very sort of systematic way. Click here for survival data, and they present not only in graphical format, but they go through in some of the writing that's very easy to understand as to what some of the statistics are, what some of the neurodevelopmental outcomes are, and they present that in a very good fashion. And so I think that based on my very limited experience, that would be a site that I would recommend to parents.
Scott, may I just interrupt there? The Epicure study is a great study, but it's population-based. So it wouldn't necessarily reflect what might happen to a baby who is admitted to a tertiary centre. We know at extreme prematurity, mortality is doubled if you're born outside a tertiary centre. So when you put all those babies together, there may be a risk of overestimating mortality because there are certain factors which may increase mortality by 50 or 100%, like outborn status or birth weight. So a site which I would recommend if you're trying to look at mortality and morbidity at extremely preterm birth is the NICHD site, which has composite data of all their tertiary centres for counselling families and takes into account antenatal steroids, birth weight and gestation. Because obviously a 25-weeker who's only 450 grams is much less likely to survive than a 23-weeker who's 750 grams. And we have to take that into account.
Thank you. NICHD?
Yes, if you just enter into Google NICHD Tyson gestation calculator, John Tyson is a neonatologist, I believe, in Texas, TYSON, you will get the survivals for 22, I believe, to 25 weeks gestation by birth weight. And the NICHD, we compared them with the Canadian Neonatal Network, very, very similar, because Canada has almost a universally good tertiary service. Yeah.
And Dr. Leonard, in response to your question, I don't know a good website from a mom point of view where I can go just to get basic information.
We have one burning question or comment.
I'm scared
really
too.
short because we're almost
Are you all
done.
out of tomatoes?
Again, really nice presentation, but I have you come back to thinking about antenatal consultation is something really interesting because you're talking to parents about a baby they haven't yet had, right? You're talking to a baby and parents in advance of even holding their child and asking them to make decisions for a child they haven't even held, maybe haven't even named. So this is a very particular area of counseling that I think still deserves a lot of research and thoughtful questioning. As far as parent information, there's a website called NICU Toolbox.
Oh.
There's also March of the Dimes website as well. And there's many other links you can get through those websites, which is more parent-oriented, like when can I hold my child?
Wow,
Right?
that's
so
great.
when can I breastfeed my child? Because really,
That's what you want to
most of us who do
know.
antenatal consultation, most of the time we don't spend talking about survival, right? We talk about what life is actually like as a parent in pregnancy,
Thank you.
or it can be.
Can be like, yeah.
Thank you, Beth and
Hi,
Scott,
Dr.
for having lived through the slot. We have to stop now. It's 9:30. It's a little after 9:30. Obviously, it's a very interesting and important topic, and that's why you got asked so many questions and lots of great discussion. So wonderful talk. Thank you very much.